Good. Well, welcome everybody. Very nice to see you all. And we're very pleased to have Kate Hough.
Kate Hough, yes.
That's all right. I looked up on the internet and it said Hough, and I thought, I was really prepared. Can't be. We're really looking forward to hearing about your research tonight. Is there anything else? I don't think. I'm just going to hand straight over to you. This is we've got 12 people online as well, and
you're recording.
And we're recording it for some people who said that they were desperate to hear tonight's talk but couldn't make it. It's not something I've done before, but hopefully that's going to work. So we will find out. So over to you, Kate.
Thank you. Well, good evening, everyone. Good evening. I didn't really know what to expect when I walked in, and there's lots of faces, which is lovely. So thanks for all coming along. So my name's Kate. I'm a postdoctoral research fellow from the University of Southampton, and my research is about the biological mechanisms of hearing loss and how the body interacts with hearing devices called cochlear implants. And over the last year, I've been doing a community engagement project whereby my aim has been to raise awareness of hearing interventions such as hearing aids and cochlear implants, and also to raise awareness of the benefits of looking after our hearing health for our brain and also our well-being. So for this talk, I'm going to tell you a bit about lifelong hearing and what I mean by that term, and I'm going to tell you about the evidence or what we know about the links between hearing and brain health and dementia. And then I'm going to go on to tell you about some of the work we've been doing at the university to raise awareness of the benefits of the... I can hear a bit of a delay. Is that?
That might be this thing. So
I can just hear me on repeat. I can just hear it. No, that's all right. And I'm going to tell you about the work we've been doing to raise awareness of the benefits of hearing interventions, such as hearing aids and cochlear implants, and also the research we've been doing to investigate the barriers to uptake of these interventions. And the approach that we've been taking is a combination of these 4 different terms that you can see on the board. So I thought I would start by just giving you a brief definition of what I mean by these terms, and then when I mention them throughout the talk, hopefully they won't be new to you. So probably all know what research is. So research is finding out new knowledge by addressing clearly defined questions with systematic and rigorous methods that could lead to changes in treatments, policies, or care. So we're all quite happy with what research is. Patient-public involvement. Now, has anyone heard of that term before, or PPI? So some of you. So this means research being carried out with or by members of the public rather than to, about, or for them. So it's about involving patients and members of the public in all stages of the research process. So I'll tell you a bit about that later on. Public engagement focuses on distributing research findings and knowledge to members of the public through different activities and events. And community engagement is about going into the community and building a partnership between the university and the community. So it's work that provides mutual benefit for the university and for the community. So I'm going to touch on each of these different terms throughout the talk. But first of all, hearing. So hearing is the sense we most rely on to connect and communicate with others. So we all have a unique hearing trajectory as we go through life, and this can be influenced by various different factors, including genetics, environmental, behavioural, and biological factors. So it can be useful to think of our life course and what we can do at the different stages to protect, preserve, and support our hearing. So the course of our hearing trajectory can influence how well we can hear. So if you have a decline in your hearing capacity, then you're likely to have a hearing loss. And this can range from mild, moderate, severe to profound. The impact of hearing loss on an individual can depend on different factors, including the severity of the hearing loss and whether it has been addressed by a hearing aid or a cochlear implant or other hearing interventions. So I wanted to start by showing you some videos to give you a sense of what it's like to live with hearing loss or deafness. So these are some videos from members of a hard of hearing club in Shirley in Southampton that I've been linking up with over the last year, talking about their experiences of deafness.
Same thing.
Oh yeah, this one doesn't have sound in it.
Yeah.
Is, I don't care what anybody says, it's a massive adjustment. If you've got any kind of sensory loss, for you to come to terms with it as a human being, it's not something you can do overnight. Yeah, I've just got, you know, I always keep saying to myself every day, I'm trying to do something better than I did the day before.
You need a lot of patience when you live with someone who is hard of hearing, especially when they don't bother to put their hearing aids in at home.
My biggest thing about my hearing loss and talking to other people is if they say something to me and I don't hear it, they say, oh, it doesn't matter, but it really does.
So age-related hearing loss or acquired hearing loss. So this is a bilateral, so both ears, high-frequency deterioration in your hearing sensitivity that is associated with aging. And it's one of the most prevalent health conditions that affects older adults worldwide. So over 65% of adults above the age of 60 experience some degree of hearing loss. And for mild or higher grade hearing loss, the prevalence increases significantly with each decade from 60 years onwards. So it's recommended when people reach midlife or older that they get regular hearing tests. And if your hearing loss is identified, then you should be wearing a hearing aid. So this figure just shows you the components of the auditory system. So we've got the, oh, you can't see at the top.
This help?
Oh yeah, lovely.
Red button at the top.
Red button. So we've got the peripheral auditory system, which is what it says up there. So that is the outer, middle, and inner ear. So the inner ear is the cochlear. And then the central auditory system is the regions of the auditory system that make up the brain. So how do we hear? So sound waves come through the outer ear and they're funneled by the pinna into the ear canal, and the sound vibrations move along the ear canal and reach the eardrum. And the vibrations cause the eardrum to vibrate. And this causes movement of the three bones that make up the middle ear, which are called the ossicles, which are the parts in green. And the final ossicle is called the stapes, and it's connected or touching a membrane or window of the inner ear, which is the cochlear. So this is this yellow structure here. So that's the cochlear. And inside the cochlea is filled with fluid. So vibrations caused that come through the outer ear to the middle ear, and we now have vibrations on the stapes touching the cochlea. This transfer of the vibrations then move into fluid-filled vibrations, which are in the cochlea. So this here just shows you a cross-section of the cochlea. So we have these sensory cells, or the hair cells, and when the fluid in the cochlea vibrates due to the sound waves that have come in, this causes little hairs on the hair cells, or cilia, to move. And this sets off a sequence of events that leads to an electrical signal being sent from the neurons in the cochlea, or the inner ear, so the spiral ganglion neurons. So a signal is sent all the way from the cochlea and then up into the central auditory system through the brainstem up into the final point, which is the auditory cortex. So that is the process of how we hear. With age-related hearing loss or acquired progressive hearing loss that one might get as they get older, this could be due to pathologies or damage to different parts of the peripheral, so the inner ear, or the auditory pathway. So it could be due to loss or damage to sensory cells within the cochlea, and significant noise damage can cause these hair cells to become damaged and degenerate over time, and they cannot be regenerated. It could be caused by loss of these neurons, which are responsible for sending the electrical signals from the inner ear up into the brain. It could be caused by damage to the wall of the cochlea, which is called the stria vascularis, which is this structure here. And this is really important for controlling the concentration of ions inside the inner ear. And that's what you need, that concentration for the electrical signal to be produced. So in age-related hearing loss, there might be breakdown of this barrier, which means the ion concentration cannot be regulated properly. And then you could also have damage or degeneration of the nerve fibers making up the auditory nerve, and also changes to the central regions of the auditory pathway. So there are different factors which can influence the development of age-related hearing loss. So cochlear aging, so aging of the tissues within the inner ear. As I mentioned, noise exposure. So extreme or excessive noise exposure can cause damage to these hair cells in the cochlea, and that can increase the development of the hearing loss as you get older. Things like the environment and genetics also influence the development and how quickly the hearing loss might progress. Different health conditions such as high blood pressure or type 2 diabetes also can increase your risk of having this acquired hearing loss as you get older. And that's to do with the vasculature in your blood vessels and the changes that then link to your hearing. Things like gender and race can also influence the development, and inflammation or inflammaging. So what's the link between inflammation and hearing loss? So inflammaging or chronic inflammation describes a low-grade inflammation that occurs in aging tissues and that worsens with aging. So it's this low-grade inflammation, so that shouldn't really be there, but it kind of is there all the time. And that has been shown to be linked to hearing loss or age-related hearing loss. So this study here found that there was an association between white blood cell count, which is just an indicator of inflammation, and hearing threshold. So they found that those people with higher white blood cell count, so higher levels of inflammation, had worse hearing, so they had lower hearing thresholds. And this relationship was greater in older people. So those people that were older and had higher levels of inflammation, they were found to have lower hearing thresholds or worse hearing. And this other paper was a review article that I put together a few years ago, where I reviewed the literature and I looked at a specific immune cell called macrophages. And I looked at the role of macrophages in the cochlea and saw that these cells they had a role in the link between risk factors such as inflammation and progressive hearing loss. So these macrophages, which are immune cells that are found in the cochlea as well as many different areas across the body, these were responsible for the link, the immunological link between risk factors or inflammation and progressive hearing loss. So untreated or undiagnosed hearing impairment can have a huge negative impact on an individual. So it can make communication with loved ones or family members more challenging. This can lead to someone withdrawing from their networks. And this can lead to social isolation and loneliness. And loneliness can increase your risk of other mental health problems such as anxiety and depression. It can also reduce your access to health services and information, could reduce your independence, and also increase burden on carers and family members. So it can cause a significant impact on someone's life and those around them. We also know that there's a link between hearing and brain health. So unaddressed hearing loss is associated with an increased risk of cognitive impairment and dementia, and an increased risk of poor mental health and low quality of life. So a study that was published in 2020, which was called the Lancet report, identified that there are 12 modifiable risk factors for dementia. And these account for 40% of dementia cases. So this includes things like smoking, physical inactivity, and low social contact. And hearing impairment is one of those. So hearing impairment is thought to be the highest modifiable risk factor for dementia, which some of you might, which is quite surprising, I think. So what is dementia? So dementia describes a group of symptoms that includes memory loss and difficulties with thinking, problem solving, and language. So dementia is not a natural part of aging, but it's caused by a disease within the brain. And there are many different types of dementia, and the most common type is Alzheimer's. So this slide just shows you the 12 modifiable risk factors for dementia, which I mentioned, which were highlighted in this big report that was published in 2020, the Lancet report. And you can see up there that hearing loss is one of them. So if hearing loss is a modifiable risk factor for dementia, that means we can do something about it, and it might reduce your risk of dementia, and also it might reduce the rate of cognitive decline. In addition to this, many of the signs and symptoms of hearing problems and dementia overlap. So this can include things like repeating questions, finding it hard to keep up in conversation, disorientation, and lack of motivation. So the crossover of these symptoms can mean that it can be quite challenging to get a diagnosis for either, especially if both are occurring at the same time. And it just highlights the point that as we get older, we should get regular hearing tests, because then you'll know whether you have problems with your hearing, and then you can kind of rule that one out. So it's really important to pay attention. So this slide just shows you some of the articles that have been in the news over the last year or so, highlighting or talking about the link between hearing and brain health. So for better brain health, preserve your hearing. Hearing aids could cut the risk of dementia, study finds. So despite the increasing evidence showing a link between hearing and dementia, we still don't know what causes this link. So this slide just highlights 4 of the mechanisms which have been described in the literature which could be causing the link between hearing loss and dementia. So I'm just going to go through each of those briefly. So the first one is the common cause theory. So this means that essentially common factors that influence both hearing function and cognitive function could explain this correlation. So things like aging, inflammation, which I've already touched on, and inflammation can be kind of caused by different lifestyle factors. So things like diet, smoking, drinking, all of those could influence your level of inflammation and therefore could contribute. Microvascular factors, so what I mentioned earlier to do with your vasculature and your blood vessels. So there's links between kind of risk factors for hearing loss and also for cognitive impairment to do with your vasculature. And then the final one is mitochondrial dysfunction. So the second theory is sensory deprivation. So the general idea is that hearing loss leads to less loss of sensory input to the cortex, which is a part of the brain involved in hearing and in cognition. So there is less verbal and emotional stimulation, there's less social interactions, and there's social withdrawal that is linked to hearing loss. And then over time, this isolation leads to changes in the structure and the function of both the auditory and cognitive systems in the brain, and this could lead to the cognitive impairment. So that's another theory. The third one is called occupation of cognitive resources for listening. So the idea of this one is that when auditory input is degraded due to the hearing loss, then higher cognitive processing is needed to compensate for this, and therefore less resources or sort of energy from the brain is available for this higher cognitive processing that's required for retaining and retrieving memories. So essentially the hearing loss is causing the brain to use energy on the trying to hear rather than thinking about memories and kind of brain function. And the third one is a kind of builds on from theory 3, but includes the addition of the pathology or the kind of problems that occur with Alzheimer's disease. So it's thought that the interaction between the brain activity related to cognition and hearing loss plus the Alzheimer's disease pathology causes this increase in the Alzheimer's pathology. So hearing loss modifies the cortical activity in a part of the brain called the medial temporal lobe, and this results in altered neuronal activity, which can cause or increase the Alzheimer's disease neuropathology, so the changes in the brain that occur with Alzheimer's. So what can people do to protect their hearing and brain health? So there are different hearing interventions available. So we have hearing aids, we have cochlear implants. So hearing aids work like a microphone, so they just amplify sounds, and these are beneficial for people with mild to moderate hearing loss. Cochlear implants work in a different way, and these replace the function of the sensory cells within the cochlea by directly stimulating the hearing nerve to send the information to the brain to be perceived as sound. So both interventions have been shown to improve or to be beneficial for cognitive health and also to improve quality of life. So several groups across the world have been trying to answer the question, which is, are hearing interventions protective against cognitive decline? So several studies have been done to investigate whether hearing interventions, such as hearing aids and cochlear implants, could actually be protective against cognitive decline, so could slow down the rate of cognitive decline or reduce the risk of dementia. So some studies have found that hearing aids do protect against cognitive decline, or they can improve cognition. So that was a really good sign. This study over here found that hearing aids actually could reduce the risk of dementia. However, some studies have also shown that there's no association. And then we started to get some research now looking at whether cochlear implants can also protect against cognitive decline. So lots of research is going on, but we don't have a definitive answer, and more research needs to be done. And there are several limitations to the studies on the previous slide. And the main one is the short duration. So in order to look at the effect of a hearing intervention, such as a hearing aid, on cognitive decline, you need to have a study that lasts several years. So some of the studies haven't been long enough. Another factor is the ethical consideration. So we know that hearing interventions, such as hearing aids and cochlear implants, are helpful for people's hearing. So therefore, is it ethically okay to have two groups where one group get the hearing aid and the other group don't? So that's something else to think about. And ideally, the research would be done using the sort of gold standard, which is a randomized control trial. And this is where there are two groups, and all of the participants that have been recruited into the study essentially go into one big pool, and then they're assigned to either intervention, and it's all randomized, and they don't know which one they're going to get. So that's the gold standard. So this study actually was a randomized control trial, and this was actually in the news in summer, so you might have seen some of the findings talked about in the news. But this was the ACHIEVE trial, which was a multi-center randomized control trial, and this was led by Dr. Frank Lin from Johns Hopkins University. And the aim of this study was to determine the efficacy of hearing rehab intervention, so in this case it was hearing aids, compared to a successful aging health education control. So I'm just going to talk you through this particular study, as it was promising. So for this study, they recruited participants who were aged between 70 and 84 and who had mild to moderate hearing impairment and had no cognitive impairment. And they recruited from two different study populations. So the first population were from sort of an existing long-standing study, which was looking at cardiovascular health. So this is the ARIC study. And just to note, these participants they were older, they had more risk factors for cognitive decline, and overall they had lower baseline cognitive scores. So that's just something to note. And then the other group or the population were just healthy community volunteers. So those were the two populations that they recruited from. And then they randomized them. So as I said, they pulled them all together, and then they were randomized to either the hearing intervention, which in this case was a hearing aid with sufficient sort of help to make sure they knew how to use the hearing aid. And the other group was a health education control. So this was it was called a healthy aging control program, where participants spent time with a health educator to learn about how to improve their health, and kind of it's related to chronic conditions as you got older. So that was a sort of program that had already been used in other studies. So these are the two groups. And just to note, both groups they made sure they saw they had equal amount of time. So that this group they saw an audiologist every 6 months, and the other group saw the health educator 6 months. So they spent the same amount of time with those in the study, which was important. So what did they look for? So the primary outcome measure was a change in global cognitive function after 3 years. So they did lots of different neurocognitive tests after 3 years to see whether the hearing intervention was better for cognitive function. So what do they find? So they found when they put the data from both study populations together, there was no significant difference in the 3-year cognitive change between the hearing intervention and the control. So when they put it all together, there was no effect. But interestingly, when they looked at the data specifically from this older group that had these risk factors for cognitive decline and had lower baseline cognitive scores, when they looked specifically at that group, they found the effect of the hearing aids were to be substantial. So the hearing aids actually reduced the rate of cognitive decline by 50% compared to the control group. So the findings or the conclusions from this study were that hearing aids might reduce cognitive decline in those who are at an increased risk of cognitive decline, but in those that were not at an increased risk, then it had no effect. So this is still really good news, and it's important because then if we can identify that hearing aids can help people, potentially those people that are already at a higher risk of cognitive decline and dementia, then if we get those people to be wearing their hearing aids regularly, then this is good. This is good for their brain health. Now, unfortunately, the uptake of both interventions are extremely low. So hearing aids, in the UK, around 2 million people currently wear hearing aids, but a further 6 million are thought to benefit but don't wear them. And for cochlear implants, only 5% of adults who could benefit from a cochlear implant actually have a cochlear implant. So there's great need to raise awareness of the benefits and the importance of both interventions, and also to investigate the barriers to uptake. So why are people not wearing hearing aids, and why do people not know about cochlear implants? So the approach that we've been taking to raise awareness and to understand these barriers include all of these 4 terms which I referenced at the start. So research, patient-public involvement, public engagement, and community engagement. So we're trying to use a combination of all of these different approaches to try and tackle these questions or these challenges. So through research, so we've been working on a quality improvement project with local clinicians who work at a memory assessment centre. So when people go for a memory assessment in a memory clinic, we wanted to make sure that hearing loss was considered. So we wanted to improve the services in memory clinics by making sure that when people went for a memory assessment, their hearing was screened for. So they were asked about their hearing. Because we did an audit and we found out that this was not routinely being done. So when people went for a memory assessment to determine whether they had dementia or cognitive decline, they weren't being asked about their hearing. It wasn't even being considered. So if someone has a hearing loss, but maybe they weren't wearing their hearing aids or they didn't really know that they had a hearing loss, then how could they possibly answer the questions of the clinician to determine whether they have cognitive impairment or dementia if their hearing hadn't even been considered? So can you see the importance of our hearing in this situation? So So our aim of this project is to make sure that hearing is screened for when people go for a memory assessment. And then if it is screened for and identified, then a different cognitive test should be used that doesn't rely so much on the person being able to actually hear the questions. And then also we want to make sure we can signpost patients to audiology services. So we want to actually encourage people and tell people while they come to a memory clinic why it's so important that they think about their hearing and they get their hearing tested. So we've been doing this through 3 different ways. The first way is through better staff education. So we've organised some training sessions for medical and non-medical staff to tell them why these hearing interventions are important and why we should even be thinking about our hearing when people come in for a memory assessment. The second one is through better patient education. So then through the staff being more informed and feeling like they can have these conversations with their patients, then the information is being passed on to the patient and they can understand the importance of why they should go and get their hearing tested alongside when they are having their memory assessment. And we've also got some leaflets and different resources that we can pass on to the patients. And the third one is through service improvement. And one of the ways that we've done this so far is change the pro forma. So we've included specific questions about hearing when people go for a memory assessment. So they will be asked, you know, how is your hearing? Do you wear a hearing aid? Have you been prescribed a hearing aid? And things like that. So it will be mentioned at the appointment and it will be kind of highlighted that it's something that we should be thinking about. Another project we've been doing has been to evaluate the access to cochlear implant services. So we've been specifically looking at a cohort of patients at the University of Southampton Auditory Implant Service, which you can see the logo just up here. So I don't know if you're aware that as part of the university campus in Southampton, we have an auditory implant service, which is one of the 19 centres within the UK. And this is where you would be referred to if you have severe to profound hearing loss, and then you were referred to get a cochlear implant. You would be sent to the auditory implant service, which is sort of part of the university campus. And I work very closely with the clinicians and researchers there to really make sure our research is kind of impacting the patients that are part of this service. So anyway, we were looking at a population of patients from this service who were over the age of 60, and we wanted to, first of all, evaluate their access they had to the centre. So we did this through a service valuation. So we looked at patient data, or their patient data, to see different factors that might have influenced their access to the service. So things like where they lived, their socio-economic background, the referral pathways, so where were they referred from, what services, what locations. So the auditory implant service covers quite a large area of the south of England. So we wanted to see whether there were specific areas that were really good at referring people and maybe other areas that weren't so good at referring people. So from the service valuation, we found that people from lower socioeconomic groups are less likely to access the centre, and that there may be problems in the referral pathway as certain services and areas were more likely to refer patients than others. So this work allowed us to identify some of the gaps and areas where we need to work and we need to invest our time to make sure that people from lower socioeconomic groups are having the same levels of access to the centre and to get a cochlear implant, and also that people across different postcodes are having the same access to the centre and to getting a cochlear implant. So this work was really important. I'll just say that this was done by Alicia, a fourth-year medical student. And the second part of this project was to use semi-structured interviews to actually identify different barriers and motivators for getting a cochlear implant. So we interviewed specifically people that already had a cochlear implant. So they were the lucky ones that got through and actually got an implant. And we remember the statistic earlier that 95% of people who could have an implant don't have one. So we only interviewed the people that actually got one. But we found that some of the motivators that led them to get their implant was things like their struggles with hearing loss, and also the support and reassurance from their loved ones. So those ones that actually went on to get an implant possibly had quite a lot of support from their family, and the encouragement led them to actually getting one. Whereas some of the big barriers were the fears and concerns around getting an implant. So there's a surgery involved, there's lots of unknown, you have to do quite a bit of training. So there's lots of different things to think about there. Possibly a denial of hearing loss, and also lack of clinical knowledge was mentioned. So possibly some clinicians aren't as clued up about cochlear implants, which is something else we need to kind of work on. So this project was really valuable to identify these different areas where more work needs to be done to make sure people, one, know about cochlear implants, and two, are actually getting all the way to the centre and part of the process ready to get their implant. Another approach we've been taking to raise awareness of the importance and the benefits of these hearing interventions, and also the link between hearing and brain health, is through community engagement. So I mentioned at the start, this is about going into the community and forming a partnership between the university and the community. So it's work that provides mutual benefit for both the community and the university. So it's not a one-sided exchange. It's dynamic, so it's about multiple engagements, not just a single engagement. And it's relational, so it's about the relationships that are formed between researchers and members of the community. So community engagement is extremely valuable for research. So members of the public should have a say in what research is done and how it's done. So involving patients and members of the public, so people part of our community, in research can improve the quality and relevance of the research, and also can increase the diversity of people involved in research, which is really important, because we want the research that we do to be reflective of the population that it's going to benefit, not just looking at one specific group. Community engagement is also valuable for the individuals involved, so they can learn new skills and have new opportunities. It's valuable for members of the community, so they can be more informed about their health. And also it's beneficial for wider society by bridging the gap between researchers and members of the community. So this is a project that I started about this time last year, and I was awarded funding from the University of Southampton Public and Community Development Fund. And they fund kind of upcoming community or public projects. And this was one that I designed. And the aim of this, my primary aim, was to simply go out into the local community and start a conversation about hearing loss. So I wanted to bring members of the community together to share their experience, knowledge, and fears around hearing loss and brain aging, and ultimately to raise awareness of hearing loss and the positive impact that making a hearing health a priority can have on your overall health and well-being. So quite a simple idea, but this is what I wanted to do, and this is what I set out to do this time last year. So there are 3 stages of the project. Again, really simple. The first stage, build relationships and connections with community groups. The second stage was to design or co-design activities which we could take into these community groups, which would allow us to start these conversations about hearing and brain health. And the third stage was running the activities in the community groups. So how do I go about building relationships? Sorry, you can't actually see the top bit, but it's all good. Building relationships with community groups. So I wanted to reach or kind of link up with groups through networks and connections that I already had. So there was this baseline level of trust. And I also wanted to reach existing community groups and go to where they are in the spaces that they already meet, so they feel most comfortable and relaxed. So instead of me going in and giving a talk and them never seeing me again, I wanted to take a different approach where I would visit different community groups, just get to know them, build trust and build relationships, and let any knowledge or information sharing come secondary to that. So I'd get involved with different games, quizzes, and even some singing. And then eventually, after a while, tell them about the work that I do and kind of the stuff that I'm interested in. So I visited different community groups, from an adult mental health group, a hard of hearing support group, and even and a Afro-Caribbean luncheon club. So a broad range of different community groups. So this is just a picture of the hard of hearing group in Southampton that I've been getting to know over the last year, and they've really welcomed me into their group, which has been great. So the second stage was co-designing the activities. So I worked with community group leads and also members of our patient public involvement and engagement group, PPIE group, which I'll go on to tell you about a bit later. And we worked together to design different activities which we could then take into the groups to raise awareness and get people talking. So we came up with a quiz with different elements that included some sound rounds to get people thinking about their hearing, some arts and craft activities. So one of them was designing a sound-friendly room to get people thinking about the challenges people might have with hearing impairment, thinking about the different materials of the room, the lighting, things like that. And another craft activity was just to use craft as a way to get people to relax and talk about kind of their own experiences. So running the activities. So you can see two photos here, and this was when we did, so we held an arts and crafts activity. So we used clay modelling, and this was in the hard of hearing group. And I asked the group to make clay models to represent their experience of hearing loss and deafness. And I didn't really know what to expect. And I don't really think they knew what to expect when they first arrived and they saw big brown balls of clay on their table. But surprisingly, and which was lovely, they all made really thought-provoking models. And then we went round and everyone sort of explained to each other why they'd made what they'd made and kind of why it was important. So it was a really good way to get people talking and sharing their own experiences. And then this photo down here was a kind of more information sharing session where we sort of, everyone shared their own experiences, and then we had a quiz and I just shared some of my knowledge, which was great. So some of the achievements of this project. So one of them is that we've been able to build new partnerships. So I've met this guy here called Steve, and he's had profound hearing loss for about 17 years. And he's been working tirelessly with his wife, Chris, for the last 10 years to support people who are hard of hearing in Southampton. And through this project, we've now met and we've linked up, and we've both got a kind of shared passion to help people with all things hearing. So now we work together, and he's now a community partner on our projects, which is great. Another achievement is we've been able to bridge the gap between the university and the local community. And this is really important for the University of Southampton, as we are a civic university, and that means we're committed to improving the lives of people living in the local area by working with them and engaging with them through different activities. So in March this year, the university held its annual Science and Engineering Festival, and I don't know if any of you have heard of it, but they run it every year, and we had an exhibit about hearing and cochlear implants. And I thought it'd be good to make some mini movies that we can play on the day. So I asked members of the hard of hearing group and also our PPIE group whether they'd be interested in being filmed talking about their experience of hearing loss and deafness. And I had a queue of volunteers, so I put all the videos together and made 2 mini movies, which now are on YouTube and you can access via that QR code, which we can use to raise awareness about how it's like for them to have hearing loss. And we also showed it at a university event where members of the public came in. So that was a real success. And we've also been able to spark conversations about hearing and brain health in older members of our community, which is really important, and hopefully I'm getting across that it's an important topic to be talking about. So some of the challenges of this project. So one of them is the time and effort that's required to actually go out into different community groups and build this trust and relationship. So obviously I have other research as well that I need to be doing at the university, and this project is a lot more kind of hands-on and requires visiting different groups. But that's a really important part of actually making this kind of a success, is building this trust and relationship, but it does require time. Another one is funding. So you need funding to support this work, and this has to be kind of provided through grant applications. So you have to apply for grants and then be successful in those grants to have money to support this work. And another challenge I found was a reluctance or lack of trust from members of the community to first of all want to engage with people from the university in some cases, and also to want to engage in difficult conversations about hearing and brain health. These are people that have just going along to their usual clubs, and it's quite a social environment, and then there's me turning up saying, let's talk about hearing and dementia. So it really is about, that's why I said it's really important to build that trust and just to get to know the groups first before trying to kind of bombard them with information. So this slide just shows you some of the groups that we've linked up with so far for this project, and we're continuing to try and reach out and expand our engagement. So that funding ended in July this year, so I applied for some more funding to make sure I can carry on this work. So I applied to Alzheimer's Research UK this time. And the aim of this project is essentially to expand upon the work that I've already done, so that building upon these links that I've made, and to move more into the brain health space, and particularly to make sure that we're reaching these less well-served communities or the seldom heard voices. So paying particular attention to these groups to ensure that we're visiting a wide diversity of people around Southampton and Hampshire. And another important element of this project is we actually now want to evaluate the effectiveness of this type of work. So we want to see whether community engagement, so going out to the community, actually can help with raising awareness, building knowledge and informing behaviour change, and also does it actually encourage people to get involved with research. So we've kind of started to build these links in the community, and now we want to build upon that and actually do some evaluation. So now I'm just going to tell you about what patient-public involvement and engagement is and our group that we've set up. So patient-public involvement is not being a participant in a research study or a clinical trial, but it means actually being involved in the design and implementation of research studies using your unique knowledge and lived experience of the condition that you're researching. So patient-public involvement is research being carried out with or by members of the public rather than to, about or for them. So we wanted to build a group where we could develop a partnership between us as researchers and patients and members of the public to enable their lived experience of hearing loss and cochlear implants to inform the research process and priorities in our group. So we set out in November 2021, we first approached the National Institute of Health Research, so NIHR, who are a big funding body, to ask them to kind of support this work. And we worked with different PPI experts to build our strategy. And we first advertised the group in March 2022. And we had our first meeting in May, where we had 8 members who came along to the university for our first meeting. And we worked with this initial group to build and expand our group over time. So we worked together to establish our aims, objectives, our group ethos. We all decided the name of our group, which is All Ears at UOS, and also our label, which we all designed and discussed together. And then by December 2022, we thought it was time to try and expand our group and widen our membership. So we started to advertise and recruit in the community, in different support groups. And we currently have about 32 people who are signed up as members of our group. And then in March this year, I started a formal evaluation to see how we're doing, how are we doing with patient public involvement, and how can we improve? So I'm just actually in the process of writing up a research paper to publish on this topic. So this is a paragraph which just describes who we are, which was written by a member of our group. So we're a researcher, patient, recipient, supporter group, and partnership of people drawn from all walks of life who are involved with or have lived experience of hearing loss and cochlear implants. So our aims are to work with the group to identify focuses for research and involve members of the group at all stages of the research process. So we had a training session in one of our meetings where we talked through the research process, and I tried to explain the different complexities of the research process, and then we tried to highlight the different stages of the process where members of the group could get involved. And we also want to learn about people's experiences of hearing loss and cochlear implants, And we want to find out about what issues are important to them, and then to turn these issues into research questions, and turn these research questions into research projects. So we've created a relaxed and informal environment where members of the group feel comfortable and confident enough to get involved with discussion. Group members enjoy the opportunity to quiz researchers and to share ideas of new and future research projects. And several members of the group have been involved in several research projects now in the design and implementation, and have been involved in reviewing project documents and ethics applications to make sure that the way that we write about our research is relevant for people who actually are going to be impacted by it. And also it's just so the research and the documents is actually understandable, and it's in a lay language. So we've created a group where there's mutual trust and where members feel comfortable now to actually get involved with public engagement events like what you can see here. So as I mentioned at the start, public engagement is about going out to members of the public and talking about research and raising awareness. So this is a photo from the Science and Engineering Festival, which was held in March. And you can see members of our group actually running the exhibit alongside me. And you can see here, Neil actually has a cochlear implant, and he was showing the kids sort of his implant and telling them how it works. And then these were some photos from the New Forest in Hampshire show in July, where we again went out, talked to members of the public, told them about hearing and cochlear implants, and tried to raise awareness. And we did this, or I did this, alongside members of the group who have actual real lived experience of hearing loss and cochlear implants, which is great. So just some final take-home messages, really. So hopefully I've got across that hearing is valuable, and it's something that we should think about and pay more attention to as we go through life. And possibly a big incentive for this is actually the links between our hearing and our brain health, and the importance of looking after our hearing as we go through life, and the fact that this can actually be beneficial for our brain health. And hopefully I've given you a bit of an understanding of our mission, which is to tackle this low awareness and uptake of hearing interventions, and to highlight the importance of these hearing interventions, and that we've been doing this through this kind of multi-pronged approach that allows us to do research and also allows us to speak to people with lived experience and use that to inform the research that we do. So these are just some words that our members of the PPIE group actually used to describe being involved with the group, which I thought is nice to show you. And this is our website, which you can have a look at. And I've also got some coffee mats, which you can take home. And on the back, you can scan it for a free hearing check, which is, I mean, there's lots of different websites that you can do it, but you can do it at home and test or do a check of your hearing, and then it might give you an indication that maybe you can go and book a hearing test. And I actually did check earlier today. Boots do hearing tests, free hearing tests for all ages, so that's a good place to start. So just before I finish, thank you to everyone in my group at the university, particularly Professor Tracy Newman, she's here, and she's been my supervisor and line manager for the last 6 years, supporting this work, and Heather and Barney, who are PPI experts who helped us set up our PPIE group, and Mary, who works at the auditory implant service, who we work closely with, and obviously members of our All Ears group and members of the community groups that have welcomed me into their space. So thank you very much for listening.
Oh, God, that was excellent.
Thank you.
You might just having a look in the chat, sponsoring that, see if anyone pops in any questions on the chat. Okay, just land that on you last minute. But any questions from the audience? And I'm going to bring the microphone to you because we've had an excellent talk on hearing, and you must make sure that everyone hears the question.
I've got two questions actually. The first is, am I correct in thinking that one of your earlier slides suggested that certain medication had an adverse impact on hearing? And secondly, do you think there is enough joined up thinking now that hearing tests have been put out into the private sector?
Great questions. So I don't know if so the first question was whether different medications actually can impact your hearing, and the short answer is yes. So some drugs actually can cause hearing loss, and you might find, or particularly for young babies that might need specific antibiotics for meningitis, that could lead to hearing loss. So there are medications that can cause hearing loss, unfortunately, but you won't be given it without asking whether you are happy with the risks. Often they're used in cases where the benefits outweigh the risks, if that makes sense. Yeah.
Second question was a little bit about privatisation, wasn't it? Is that
Yes.
right? In terms of the way that hearing tests are done. Any comments and opinions on that?
I believe that the hearing tests that are done in private places are, the same hearing tests that you would receive if you went to audiology department at the hospital. You just have to pay for them in some cases. So the No. Yeah, so depending on where you go and on your age, will be whether you have to pay for a hearing test or not. And then obviously in some places you might need to then pay for a hearing aid, compared to if you went through the NHS only route, where you would go to your GP and say, I think I've got hearing problems. They might then refer you on to audiology department in the hospital. Then you'd go along.
They don't anymore.
They don't anymore.
But there's people like Specsavers and Boots they refer to.
Well, just I don't know if you saw, I mentioned in my email thing that the Village magazine were very entrepreneurial when I was advertising. We put our advert in the Village magazine. I don't know if you notice that every month, but this month there's a section on care, and they put our advert for this session in the care section, and they also put it adjacent to a whole article on the Royal National Institute for the Deaf and about getting hearing tests. So that was a very helpful article in terms of offering full tests, as I understood the article.
Yeah.
So that's a useful resource to go and check that. And I think we've got a question coming in online. Is that correct?
No, nothing online, but I have a question.
Oh, you have. Well, if it's yours, look, take the question at the back.
Well,
It's there for when I
But just to say on the sort of hearing tests, I just want to ask this gentleman if you went to, they referred you to Specsavers.
I asked for a referral,
Yeah.
and both my wife and I are going to Specsavers to have a test.
Yeah.
But she will independently go to her diabetic nurse for a type 2 diabetes test. So there's two lots working.
Yeah.
How does that marry up with the fact that if you're having a mental test,
Yeah.
that they have the right information?
So the hearing test results should be sent back to your GP, and which is what should be happening. And what we are trying to encourage people to do is, if you do go for a hearing test, in the same way that you might know your blood pressure reading off by heart, I mean, some people, I imagine, probably don't, I don't, but what you could do is when you have a hearing test, say, can I have a copy of my audiogram, please? Because it's your own test results. You can get the results, and then it's good for you to have. And then if you did go back to your GP, or if you did go to a memory clinic or anywhere else, you could say, this is what my hearing function is. So that would be sort of a tip for all of you, if you did get a hearing test, to ask your audiogram, or to see your audiogram, or to take a photo of it on your phone, because it's your own results, and it's good to kind of have those values.
Excellent. We've got a question online, but I'm just going to take a question from that lady back here first.
What I'm wondering is, the last couple of years we've had COVID, how has it impacted on your studies?
That's a very good question. So particularly, I mean, the study that I talked through earlier, the hearing aid trial, part of that happened during COVID, so they had to sort of do some of the testing on the telephone and via kind of online appointments. So obviously it does impact studies and how they're done. I mean, it also can impact recruitment. Yeah, so it can cause more challenges in terms of actually reaching people and taking the right measurements at the right times. Definitely.
Right, an online question from Cliff Archer. I have hearing aids and understand that cochlear implants are much more expensive than aids. How would I go about investigating cochlear implants, and would they be advantageous to me?
Great question. So cochlear implants are for people with severe to profound hearing loss. So you're kind of at the other end of the scale in terms of the hearing, and they're for people that no longer receive benefit from hearing aids. So if your hearing is so bad that you fit into the severe to profound criteria, and therefore you no longer receive benefit from the hearing aids, because hearing aids are only working the sort of functions of your inner ear, so your hair cells and your nerves still working okay. If they're not working okay, the hearing aid isn't going to be able to help, because it won't be able to amplify the sounds, because the sounds, do you see what I mean? The signals aren't coming through. So to find out about cochlear implants is when if you go for a hearing test, then to ask them, kind of what criteria do I fit in, and am I eligible for a cochlear implant? And once you ask that question, the clinician is therefore they have to kind of check. If you ask them, am I eligible for a cochlear implant, they then have to check and make sure that they've checked that your hearing function, see whether you fit into the specific criteria, and if you do, then there is no cost to you. So if you fit into the NHS NICE guidelines for a cochlear implant, then you don't pay for them. You can get them on the NHS, so they are expensive for the NHS. They cost about £20,000 to actually get, but in the sort of long run, they're beneficial. They've looked at the costs, and the benefits outweigh the costs in terms of the NHS. So the cost shouldn't be a barrier. If you're eligible and you will benefit, then you should go for one. And I try to tell people as well that age should not be a barrier. So people at the auditory implant service in Southampton, I think the oldest recipient of a cochlear implant was about 95. So you shouldn't be put off. Yeah, you can get one, you know, right into your 90s, and it could still provide benefit. If you have significant hearing loss, where you cannot quite literally hear anything, and then you can get a cochlear implant. In most cases, it will bring some sound. So some people with a cochlear implant can access music again, they can access conversation, they can access employment. So age shouldn't be a barrier, is my message about cochlear implants. So
excellent. Nice, really good at this sort of thing in terms of approving things that make sense and are cost effective. We should be very proud of that aspect of our healthcare system. Oh, no. So,
another online question, this time from Judith Marriott to everybody. Oh yes, there are so many establishments that want to sell you an expensive hearing aid when there may be no need for it. I went to one establishment where the lady showed me the hearing aids, told me which one she would recommend and the price. It was about £3,000, and hadn't even given me a test at that point. Is it more beneficial to pay for a private hearing aid rather than an NHS one?
Good question. I think a lot of people ask me this question, and obviously I'm not a healthcare professional, I'm a researcher, so I'll give you my view in that sense. In terms of the quality of a hearing aid, the ones that you can get on the NHS now match the ones that you can get privately. Obviously, probably not the far high-end ones, but in terms of kind of what the NHS are offering now no longer lags behind the private sector. So you're not going to get a worse hearing aid if you go on the NHS. The thing that you might struggle with is possibly there might be, you know, longer waits and things like that. But in terms of the quality, you can get a really good one on the NHS. You don't need to pay £3,000 for one.
Yeah, I don't know if there are any experts in the room, but I know there's been a lot of research into the technology of hearing aids.
Yeah.
And that has improved dramatically over the years. I mean, I'm
not convinced of that last statement, actually.
Oh, you know.
The problem with age-related hearing loss appears to me. The problem with that age-related hearing loss is that you lose the high frequency. The high frequencies are necessary for distinguishing things like consonants, which is basic for the understanding of words. Vowels are not too bad, consonants not. So you have to concentrate all the time when you're listening. The other point, I think, is that you say a lot of people don't wear their hearing aids, and that is because the hearing aids do not do very much for those high frequencies which you have lost. And I think if you amplify something for which you have a zero capability, you're not doing anything. And I think what these expensive hearing aids do are peripheral things like noise suppression, which can possibly help and probably do help, but they're not fundamentally changing the ability to hear high frequencies. That's my opinion.
Yeah, comment.
Yeah.
As you said, Kate, if there's a disconnect at a certain frequency, doesn't matter how much you amplify.
Yeah,
I guess it's not
exactly.
the case.
There reaches a point where, yeah, the hearing aids will no longer benefit you, and that's when a cochlear implant might work. And as I agree with the gentleman that, yeah, in some cases, whether you get a kind of more expensive hearing aid, it may also not help.
Which is in contrast to what Frank Lynn was stating in one of your slides. He's saying they can give considerable benefit. But I'm thinking in a lot of cases for the age-related hearing loss, they're not considerable benefit. And that is why people are reluctant to actually put their hearing aids in, because they experience very little benefit.
Yeah. Well, another thing also with hearing aids, unfortunately, is that you have to get used to them as well. So for some people, that if you wear them and for a couple of days and you haven't worn them before, then it might not feel very comfortable. It might not feel like you want to keep them in. This lady's nodding.
I've heard that said so often, plasticity of the brain and everything, that you have to wear your hearing aids for quite a while to get the benefit. It's no good putting them in for one day and saying these don't work.
Yeah, exactly. Yeah, so you do have to kind of wear them and get used to them and get used to how the sounds sound different, and the sounds will sound different between a cochlear implant and a hearing aid as well. But your brain does get used to them, and for some people that don't have profound hearing loss will get some benefit from hearing aids.
Hello.
Hello.
Thank you very much for an inspiring talk.
Thank you.
I just wanted to ask if you had any comment on the impact of the build-up of earwax and its impact on hearing, and the fact that the removal of earwax is now only available as a private service.
Yeah, this is something I get asked about a lot as well, and I was asked about it earlier today at a different talk. And unfortunately, yes, so the build-up of earwax, which also kind of can accumulate over time as well, so it could be associated with kind of older age. It can cause hearing loss because the middle ear is blocked, so the sound waves can't travel through the middle ear to get to the inner ear. And unfortunately, if you want the earwax removed, because you have significant hearing loss because wax is blocking the sound, you have to pay now. They won't do it on the NHS, and you have to pay for the service, and it can cost from probably about £60 to £300. So I don't agree with that at all. Yeah, unfortunately that is the case. But I would say again to stress the importance that I think I've gone. I'm still here. If you have got hearing loss because of the earwax has built up, then in the same way that if you had hearing loss because your hair cells aren't working very well, in terms of the impact on your well-being, on how you can communicate with others, on your brain health, if it went on for a long time and you had this blocked ear and you couldn't hear, then that's going to impact your health in it's going to kind of snowball. So it's still a good reason to kind of try and get it sorted out if you can afford it, because you don't want to have, I often say that it's like your arm muscle. So if you don't kind of exercise your bicep, it's going to get weaker. So if you don't exercise your hearing system and the sort of signals between your ear and your brain, then over time they kind of get less, they get weaker. So if you have something that keeps stimulation like a hearing aid, or even just like sound normally, then that keeps it kind of fired up, which is a good thing.
You painted a picture of the benefits of hearing aids for older people.
Yeah.
That's very clear. Has there been any research amongst younger people, those born with impaired hearing, and are the benefits similar?
That's a very good question. So in terms of people that are born deaf, so now children will get picked up on the newborn hearing screening, and they will have, so babies have to have a hearing test essentially in the first kind of couple of weeks. And if a hearing loss is identified, then they'll be referred to audiology, they might get hearing aids. And then if they have profound hearing loss, then they'll be referred to get 2 cochlear implants. Now, obviously, the deaf community, so people who are part of the deaf community, which is a whole kind of, it's got a culture and it's got its own language, which is British Sign Language. Those people might not use necessarily, they might not get a cochlear implant, or maybe they might wear a hearing aid, but they might use sign language. So they're kind of they're keeping the system firing, if that makes sense, because they're communicating in different ways. So I'm not really answering that specific question, but it's for children, there are different worries. So for young children, particularly in the first couple of years of life, it's really important that if they do have a hearing loss, it is identified and sort of acted upon, because those are the years when they're kind of the pivotal years where they're learning to speak and they're learning to interact. And obviously, if a hearing loss is unidentified, it can cause significant problems to language development and kind of schooling and things like that. So that's this kind of real importance at that early age to get it identified. But
maybe I can take the chairman's privilege to have the last question.
Yeah.
So this is brilliant. I love it. Really, really nice work.
Thank you.
How does this link to sort of like national public health policy? Is there any attempts to, like you said, having to pay for earwax removal, something you disagree with? I think probably everybody in the room does.
Yeah.
If that's the effect on your health of not hearing well, then
yeah.
surely that feels like something that if you can't afford it, you should get it
yeah.
on the NHS. So how can we influence public health policy?
Great question. And this is something that we've actually been talking about in our group the last couple of weeks, because we've been doing a lot of work in the community in the local area, and we've been making these kind of key links with different members of the community. And now we're thinking, how can we actually make a bigger impact? And this will be through influencing policy. So we've got a meeting lined up with the policy team at the university, and we're actually going to try and kind of run with this, and we've got some different key people that are kind of we're going to work together with and try and raise awareness that this is a public health issue, and it's something that if we kind of put some focus on, then it can reduce the costs of the NHS, it can improve the health of people, and it can improve the quality of the year, the older years of someone's life. So it can reduce disability and improve quality of life at that particular period of life, where on a lot of statistics, kind of those things are going down, essentially. So yeah, that's a good question, and that's something we're kind of going to put some efforts into, because
it may even save some money in terms of support costs.
Exactly,
like
yeah.
People are more independent because they can hear
exactly.
better. So there may be some return to the healthcare system through that.
Yeah.
Anyway. Well, what an excellent evening. Let's express our thanks again to Kate. I don't have my program in front, but the next month's talk is also about the mind, and it's by a psychologist who's going to come and talk to us about the vagaries of are thinking. Stuff like that. I won't say any more. You can look on the website and check it, and you will get a reminder email. If you're not on the email list, then either sign up on the website or let Annie or I know your email address, and we can send you mailing things. So,
Can I just say one more?
oh
One
yes,
more
of course you can.
I'm just going to leave this up. It's a study that we are currently doing, so you can just have a read before you leave if you think you know anyone that might fit our kind of criteria. But we're investigating. We're trying to understand why people aren't wearing their hearing aids, and we are particularly interested in people who have been diagnosed with cognitive impairment or dementia. But we're looking from the perspective of the carer or loved one. So it's just the project is essentially a questionnaire that's got kind of scaled questions and also some free text questions. So I'll leave it up there if you know anyone that might be eligible and would be interested in taking part. And also I've got some kind of coffee, beer maps, whichever you prefer, just if you want to take home, and it's got the hearing check and our website on there as well, and also some other leaflets if you're interested. That's it. Thank you.
So much. Very nice.
Oh,
Very much.
thank you.
Yeah. 17 people.
Wow.
Well,
Yes.
so so that's a really good turnout.
Sorry? Okay. Okay.
Yeah, you spell out.
Yeah.
So you've got to go.
I'll have a look.
I'm sure it will be.
And also, you've got a very good voice.
Oh, really?
Well, it comes out very clearly.
Yeah,
I mean,
that's
some
good.
people don't enunciate.
Yeah.
It's like me.
I've had a lot of, over the last year, I've speaking to a lot of different people with different levels of hearing loss, so I really try and make sure that I